Welcome. We are pleased to offer you today's webinar, Supporting Health Behavior Change Through Motivational Interviewing. My name is Kathleen Russell-Babin, and I welcome you to this Meridian Health Institute for Evidence-Based Care webinar. Continuing education credits are available for this offering. Participants must remain for the entire session in order to claim continuing education credits. If you are not in a group session, you must also fax the evaluation to 732-481-8599 with the contact information written on the evaluation so we may return your certificate for you. If you're in the group session, please just complete the appropriate form you are provided. A few housekeeping announcements. For accreditation, we must state a few of these items, and we ask you to refer to the page to go with it. For Nursing 1, nursing contact hour will be provided by the Meridian and May Center for Nursing. Accredited status does not imply endorsement by the Ann May Center for Nursing. Meridian Health is also accredited by the Medical Society of New Jersey, and Meridian Health designates this live activity for a maximum of 1 AMA PRA Category 1 credit. There is no commercial support for this activity. Speakers have declared that they have nothing to disclose, and this program is considered free of bias. This webinar will be available for viewing for at least the next 6 months from Meridian employees via the webcast website at www.meridianiebc.com. It will be available online 24/7 throughout this time in YouTube and Media Play formats. Availability will begin actually 2 to 4 weeks after this live broadcast. Please encourage your colleagues to complete the webinar. We do not have time for questions today, but if you have any for our expert, please send them to the Institute for Evidence-Based Care, care of me, K. Russell Babin at meridianhealth.com, and we will ensure that you receive a prompt response. The objectives of our program are to define motivational interviewing, recognize the stages of change in their relationship to motivational interviewing, describe the spirit of motivational interviewing, describe basic techniques that would be useful in a variety of healthcare settings by different disciplines, and discuss the role of the clinician in motivational interviewing. About our speakers. As I said before, my name is Kathleen Russell-Babin. I'm the Senior Manager for the Institute for Evidence-Based Care, and I have a special interest in motivational interviewing in the context of health coaching. But our main speaker is Johnnie Bryant. Johnnie Bryant, LCSW, is Clinical Program Manager for the Adult Partial Hospital Services for Meridian Health. He has a master's in social work with a concentration in health, mental health, and aging, and a bachelor's in music therapy from Shenandoah Conservatory of Music in Winchester, Virginia. Johnnie is a pivotal member of the Behavioral Health Services team supporting performance improvement, operations, and continuing educations for clinicians in the partial hospitalization program. I'd like to begin to set the stage for you by briefly sharing with you a bit of the research about motivational interviewing. And we've been lucky enough to have a series of systematic reviews or meta-analyses that summarize this literature. Motivational interviewing, or adaptations of it, have been found by Burke as far back as 2003 to yield some moderate effects compared to no treatment involving alcohol, drugs, diet, and exercise. Motivational interviewing use in alcohol and drugs has long been supported by research, but MI in health behavior improvement is a more recent finding. So the findings in diet and exercise were particularly valuable in this study. The results, however, did not support the use of MI for smoking or HIV risk behaviors, and they examined 30 studies. Although they said that these results with their effect sizes were moderate, they are very respectable. And they did not appear to fade significantly over time, which was an important contribution of this study. They did, however, find that higher dose studies yielded larger effects than lower dose studies. Hatima, Steele, and Miller in 2005 offered a newer meta-analysis of 72 different clinical trials, ranging a target of a variety of problems, including alcohol, smoking, HIV/AIDS, drug abuse, overall treatment compliance, gambling, eating disorders, diet, and exercise. And they did find short-term between group differences were favoring the motivational interviewing with a sizable effect size of 0.77, although this did decrease to an effect size of 0.30 at follow-up at 1 year. In 2011, I was fortunate to find a Cochrane review of smoking cessation, as the Burke study had not indicated that this was working in the right direction for our use. This particular meta-analysis compared motivational interviewing to brief advice or usual care and showed a modest and significant effect in the increase in quitting. Again, longer sessions were more supportive than shorter sessions, and the overall evidence favored motivational interviewing. And finally, again, another meta-analysis by Armstrong, specifically related to weight loss, showed a medium statistical effect. The weight loss was about 3.5 pounds or 1.5 kilograms. However, this, although it was statistically significant, may also still be clinically relevant in some cases, as weight loss as low as 1 to 9 pounds has been shown to be associated with positive health effects in overweight diabetics, and a 3% weight loss in most individuals can have some improvement on metabolic control. Those demonstrating the greatest weight loss use MI as an adjunct to other weight loss programming, which was an important clinical clue. One study noted that motivational interviewing processes significantly increased attendance at the weight loss programming, and the longer duration of support had a greater effect on weight loss. Overall, these studies support the use of motivational interviewing outside the strict use of alcohol and drugs, and moving on into health behavior improvement. So with that, I'd like to go on to the real world and give you Johnnie Bryant, who has used motivational interviewing in his own practice and has much to share with you today.
Okay, thank you, Dr. Russell Babin. I appreciate that introduction. Good afternoon, everyone. I'm pleased to have this important discussion with you about motivational interviewing. Motivational interviewing is an evidence-based practice that's been found to be quite effective in helping patients with co-occurring mental health and substance use disorders make positive changes in their lives. As we will discuss, motivational interviewing techniques can be utilized effectively in a variety of healthcare settings and purposes, where in order to improve the overall wellness of the patient must make some changes, often difficult changes. Most importantly, motivational interviewing is a practice that promotes a collaborative, person-centered form of guiding to elicit and strengthen motivational change. Okay, so let's get to it. Why do people change, and what is change? Okay, so when we think about change, change is to cause to be different or transformation. Well, people make changes for many reasons. I'm sure you can think of some things that you'd like to change in your own life. In fact, I'd like you to kind of sit back and think about some of the things that you'd like to change, and think about what are the motivational factors that would help you to make that change. On the converse, also think about what are the things that are holding you back from making those changes. I'm also sure that you can think about the people that you're working with currently, and the types of changes you'd like to see them make. You know that even small changes in their behaviors could significantly improve their overall health and wellness. For example, as we talked about earlier, obesity, heart disease, diabetes, often sometimes small changes, maybe large changes, can improve their lives greatly. Today, the kinds of change we'll be discussing are ones that move a person towards wellness and recovery. So let's look at the word recovery, or what recovery means. Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life and strive to reach their full potential. And I think important in this definition is a self-directed life and strive to reach their full potential. The techniques we will discuss could be used with your patients, co-workers, friends, or even family members. So let's define motivational interviewing. The definition of motivational interviewing has changed over time since its inception in 1983 by William R. Miller as he worked with problem drinkers. Motivational interviewing focuses on exploring and resolving ambivalence and centers on the motivational process within the individual that facilitates change. It differs from more coercive or internally driven methods of motivational change, as it does not impose change that may be inconsistent with the person's own values, beliefs, and wishes, but rather supports change in a manner congruent with the patient's own values and concerns. Motivational interviewing is a collaborative, goal-oriented method of communicating with particular attention to the language of change. And as we go on today, we'll talk about what some of those clues are to the language that the patient will give you that they're ready to make some changes. It is designed to strengthen an individual's motivation for movement towards a specific goal by eliciting and exploring the person's own argument for change. And I think that is a very important piece of the definition to keep in mind, eliciting and exploring the person's own arguments for change. So when we look at the types of change that we're looking at, basically we're going to look at three different types of behavioral change. The first one is coerced. Well, coerced is like ordering someone to change. You must lose weight or you're going to die. Or warning, if you don't start exercising, I'm afraid you're going to have a heart attack. And that may be true, but when the patient's listening to you, they may not be hearing the message you were intending to get across, or threatening. Then there's convenient change. Well, we go to the lunchroom, I eat unhealthy snacks, but they take the unhealthy snack machine out. Now there's only apples, oranges, and water, and I'm hungry, so I make the change because I really don't have a choice if I want to eat a snack. Internalized. Internalized is I want to change because it meets my needs and it is consistent with my values. So I'm going to tell you a little story. When I was at Piedmont Geriatric Hospital in Virginia, I knew this young doctor. His name was Dr. So, and I smoked. I smoked about 2 packs a day. And I was sitting in the chart room, and he grabbed me by the shoulders and took me out in the hall and showed me this older gentleman who had an oxygen tent and a mask over his face, and he looked at me and he said, "You're going to look like that if you don't quit smoking." He walked away. My first thought was, no, I'm not. I'm 25 years old. I'm not going to look like him. And I didn't think about it again. Then another friend who was a psychologist, and he said, Johnny, I think the only reason you smoke is because you want to be like a grown-up and show that you're an adult. I thought to myself,
no, I smoke because I like it. In both cases, neither one of them had any motivational value for me. I will tell you that I did quit, and my motivation was cigarettes cost too much money for me. The value wasn't in my health at that time. The value was in saving money because I was going to graduate school and I couldn't afford to pay that kind of money for cigarettes. And also at the time they had increased the taxes on cigarettes. So we need to find out from the patient what motivates them. Collaboration. The spirit of motivational interviewing. Collaboration between the clinician and the patient, and drawing out the patient's idea about change and emphasizing the autonomy of the patient. It's a calm, caring approach with appreciation for the patient's experiences and their opinions. So let's look at collaboration versus confrontation. Collaboration is grounded in the viewpoint and experience of the patient. No, not the clinician as the role of the expert. You know, patients wouldn't come to you if they didn't think you had skills and knowledge that they could use or learn from. I think they already see you as an expert. But they want to be a part of the solution. You know, I think all of us want to have or be in control of our own lives, and collaboration helps us do that. Confrontation in motivational interviewing often can challenge the power relationship between the clinician and the patient. And what I mean by that, if you're talking to your patient and you know, I've educated you 100 times about what you're supposed to do, and you're not doing it. Just do what I tell you, and it'll work. Because I'm the expert. If that were the case, everybody would be cured because everybody would listen to what we tell them. I think there's a different way that we can approach that has been proven to be more successful to help make the changes that the patient needs to help improve their lives. So, Dr. Russell and I are going to do a little role play right now. And we're going to demonstrate 2 forms of interviewing. Okay? Before you leave, Mrs. Smith, I'd like to review your recent lab work.
Is there something wrong?
Yeah, your lab work indicates that you're pre-diabetic.
Oh, wow. I never had diabetes.
Yes, your records indicate a family history, which makes the changes I'm going to tell you to make even more important.
Oh, the lab medications? I really hate needles. I'm not going to do that.
Well, why don't you just lose 20 pounds in the next 3 months, and we'll see where you are with your lab work. After all, you don't want to end up like your mother. Now, do you have any questions?
Well, I don't think I can lose 20 pounds. It's so hard.
Well, just change your diet and get moving. You can do it if you stick with it.
Well, can't you just give me some pills to help me lose weight?
Don't worry. Just change your diet and exercise. I'll see you in 3 months.
Okay, but don't get your hopes up.
I'll see you in 3 months.
We'll just have to see about that.
Let's move on to our second role play. Before you leave, Mrs. Smith, I'd like to review your recent lab work.
Is there something wrong?
Yes, your lab work indicates that you're pre-diabetic.
Oh, wow. My mother had diabetes.
Yes, your records indicate you have a family history.
Well, I need medications. I hate needles, and I'm not going to do that.
Well, before I try to answer those questions, would you mind telling me more about your concerns about what I just said?
Well, I know that losing weight would be helpful because when my mother lost weight, she was able to stop taking her diabetic medications and doing quite well. She still watches her diet, but I'm not like her. I'm just like a yo-yo.
Oh, it sounds like you've had bad experiences with losing weight. Can you tell me about that?
I've tried every diet known to man, and I just cannot lose the weight and keep it off. It's so hard for me. But I hate medications, and I don't want to do daily injections.
What have you done in the past in terms of weight loss that worked best for you?
Well, I have to admit, Weight Watchers worked, but I stopped going.
Well, I hear you saying you understand that losing weight could lower your risk significantly of becoming diabetic and needing medications. I know it must be frustrating to feel like a yo-yo in terms of weight. However, you also stated that Weight Watchers worked, so you have had success.
Yes, I have lost the weight before. It's the keeping it off that's hard.
Okay, so on a scale from 1 to 10, how motivated are you to lose weight?
Well, I am a 7. I just want to lose the weight, but I'm afraid of putting it back on.
Okay, well, how motivated are you on a scale from 1 to 10 not to require medications to manage diabetes?
Oh, for that I'm a 10.
So, what do you think that means to you?
You know, I think losing the weight is certainly worth it. I'm going to call Weight Watchers and give it another go. How much should I lose?
What goal would you like to set?
Well, I'll go for about 20 pounds.
Okay, I think you have a great plan. How about I see you in 3 months, and you can let me know how things are going. Okay, doctor, see you in 3 months. Okay, so in both of those examples, we see a more coercive style, and the other one we see a more collaborative style in which the patient is much more likely to engage in behavior that talks about change. And also in the second example, you heard a lot more change-oriented conversation from the patient. The next section we'll talk about is avocation versus education, closing ideas. We want to draw out the individual's own thoughts about change, not impose our opinions. In the case with our patient, Mrs. Smith, her real motivation for making changes was not to have medication. It didn't have necessarily to do with weight loss in this case. So we drew out from Mrs. Smith what it was that would motivate her to make those changes. It wasn't the physician's opinion about why that would be helpful. It was Mrs. Smith. She already had the information. And oftentimes our patients have the information. We just need to help them bring it out. And the change was internal because for Mrs. Smith, she wanted to make the change, not to take medications. Autonomy versus authority. In motivational interviewing, the clinician is not the authority figure in terms of change, but a collaborative partner. Again, helping to draw out the patient's own reasons for change that fit their values and their needs. The thing we also need to recognize is that the power to change rests with the patient. I don't think I'm, as a physician, as a clinician, going home with my patient and seeing what they're eating or changing their diet for them or holding their hand to exercise. The patient must make the change. And from a motivational interviewing standpoint, when the patient is in control of setting the goals, making the changes that will work for them, it's empowering. They're in charge. And they have a partner, you. You know what their goals are. You know why they want to reach them, and they believe you can help them. Recognizing the old saying, there's more than one way to skin a cat. Or, if the bus is going in your direction, why do you have to be driving? If the patient says, I'm going to go home and lose 20 pounds, and they have a plan that makes sense, you both discuss it, well, the patient's way, that's the way to go. That's what will work. If it doesn't work, then you can come back and discuss what happened. Recognizing multiple ways that change can occur. The patient is encouraged to develop a menu of options. Well, maybe Weight Watchers works for some people. Maybe it doesn't. Maybe it's Jenny Craig. Maybe I can't afford Jenny Craig. Maybe it's jogging. Maybe it's something totally different. But we want to elicit from the patient a menu of options, sometimes that they may have used in the past that were successful. And we may have to explore with them some of the barriers to what happened this time, or to make that successful again. Okay, so let's look at the stages of change. As we all know, as we think about our own goals for change, change doesn't happen overnight. So, in motivational interviewing, here are the stages of change. Pre-contemplative. That means you have no plans to change within the 6 months. I'm overweight, and I'm not going to do anything about it. You're not going to change anything. Contemplative. Well, I'm considering, maybe I think I should lose some weight. But I don't know. I'm just thinking about it. Preparation. I'm going to get the phone number, or maybe I'll look up the phone number for Weight Watchers. I know there's a meeting at the hospital, and maybe that could work. Action. Okay, I'm going to the Weight Watchers meeting. I'm there. Here I am. I'm sitting there with my plan in hand, and I'm starting something. Maybe I haven't lost a pound yet, but that's the action phase. I am doing something. Maintenance, that's about 6 months where whatever goal I have set for myself, I'm now maintaining that goal. And then there's relapse prevention. And if anyone out there has tried to diet before, I suspect there's a few, that's the hard part, relapse prevention. So helping the patient put in place a plan that helps them to maintain the gains that they've already made. So how do you know when someone is wanting to make change or saying things that indicate that some internal change wants to be made? So we look at change talk, desire. It's the first thing. Does the patient want to make the change? And we hear words or phrases like, I want to, I should, that would be great. Then it comes to ability. Can you make the change? Well, I can. I could go to Weight Watchers. I can change my diet. I can buy fruits and vegetables. In the case of Mrs. Smith, her change talk was, I'm going to call Weight Watchers. I think I can do that. But initially she didn't believe she could lose weight because she felt like she had yo-yoed so many times that it wasn't possible for her. But the clinician also helped her point out that, you did do it. You had success. Need. I must make the change. Now, the patient's need may not be the same as your need. For Mrs. Smith, her need was not to have needles or medication. That was her need. And that was her motivator. And then the last 4 action phase would be I will, I do. Those are phrases that let you know the patient wants to make the changes. So let's look at the 4 core principles of motivational interviewing, sometimes referred to as REDS. Roll with resistance. Okay? Sometimes, we think of resistance as, and here's non-compliant. Well, no, let's explore the reasons why the patient wants to make the change or is not wanting to make the change. And one of the techniques, and we've all used these techniques sometimes, is to kind of look at the reasons why. For example, Mrs. Smith, what would be the worst thing about losing weight? And what would be the best thing about losing weight? And then what would be the worst thing about not losing weight? And what would be the worst thing about not making the change? So in the 4 quadrants, we're looking at the best for both losing and not losing, and the worst for losing and not losing. Or the best for losing and not losing. And when the patient makes out those lists, you can see what's most important to her. So in Mrs. Smith, her quadrant would be the best reason for losing weight would be not getting the medication. The best reason for not losing weight would be not experiencing that yo-yoing. But for her, not having the medication outweighed the yo-yoing. When we're talking to our patients, we want to express empathy. We want to be empathetic. We understand that changes sometimes can be very difficult to make. We want to develop discrepancies. And by that, when we talk about motivational interviewing, we think about Rogerian therapy, which is kind of listening and a lot of reflective listening with the patient. In motivational interviewing, you're actually being a little bit more directive in terms of picking out discrepancies and bringing them to the patient's attention. Losing weight is hard, but you say you don't want medication. That's a discrepancy. There is the patient's ambivalence. So we're working with ambivalence. Support self-efficacy. You did make changes in the past. I believe you can do it again. How best do you think you can do it? I had a patient in my office. She was clearly obese, probably, I guess, morbidly obese. So I said to myself, as the clever clinician that I am, that I'm going to help this young lady lose weight. So when she came into my office, so I said, okay, so today why don't we kind of talk about your weight? I noticed that it's, you're overweight. So what have you done with your weight lately? She just looked at me. I said, is that a concern for you? And she said, no, I don't want to lose weight. Well, it turns out that she enjoyed being overweight. She wasn't a chubby chaser, she was a chubby chasee. She liked that was her motivation for maintaining her weight. So we have to recognize that we can't make assumptions about why people want to change or don't want to change. In her case, it had nothing to do about motivation or dieting or anything else. It was a completely different thing. So she educated me about working with a patient and really listening to what they had to say. So in that end, we want to ask open-ended questions. For example, if I say, do you have concerns about exercise? The answer could be yes, or the answer could be no, and that would be the end of the conversation. Or I could say, would you please tell me about your concerns about exercise? What concerns you about exercising? An open-ended question gets you much more information than closed-ended questions. Affirmations. Find the successes. Everyone has successes. Everyone. So find those successes in your conversations with the patient. For example, again, with Mrs. Smith, you've done it in the past. Reflective listening. I hear you saying. So, reflecting back what the patient said to you. This really helps the patient to know that you're listening to them, because you can't really do reflective listening if you're not listening to what they're saying. And summaries. Sometimes your patients may go on for a little while explaining their situation, so you want to be able to summarize it again, so to show that you understand what they're telling you. So how can we go about kind of eliciting some change talk? A simple technique that we used in the example was a change ruler, on a scale from 1 to 10. And that scale means whatever it wants to mean to that patient, but 10 being the most and 1 being the least, it gives you an idea of where the patient is, and also helps you to start with where they are. And as we talked to before about the decisional balance, what's the best, what's the worst, your concerns. Now here's some things you want to avoid doing in motivational interviewing as a clinician. You want to avoid ordering or directing or commanding the patient to do things. You want to avoid warning or threatening. And you want to avoid giving advice. Well, that sounds odd, doesn't it? Well, the ways you give advice in motivational interviewing is you ask permission. Would you mind if I gave you some advice? If a patient says yes, you say, okay, well, here are some things that other patients have found helpful. What do you think? So you're again, joining with the patient and making some suggestions for them. But in a motivational interview, you always want to ask their permission to give suggestions. Persuade with logic or arguing or lecturing. Going back to me as a younger man, seeing someone else with an oxygen tank that smoked most of their lives and now has end-stage emphysema, that didn't persuade me. It was logical that it was unhealthy, and I knew it was unhealthy, but that didn't persuade me. So logical persuasion doesn't always work, or lecturing doesn't work. Moralizing or preaching. All people who are overweight are lazy because they don't exercise or do anything. My goodness. No, we want to work with the patient to find out what will motivate them to make the change, or what motivates them to stay where they are. Sometimes it's fear. I'm afraid if I try again, I'm just going to fail. Why do I want to keep putting myself out there to fail? And as a clinician, you can point out their successes and help develop strategies that will help them be successful again. And in some cases, it may be medication for weight loss, or it may be surgery. It could be lots of different things. And that's one of your roles as the clinician to say, you know, if these are barriers, may I make some suggestions? Here's some other options for you. Disagreeing, judging, criticizing, or blaming. The reason you're fat because you're sitting on the couch all the time. My goodness. I know no one would say that. That's just an example. Shaming, ridiculing, or labeling. Interpreting or analyzing. Again, my friend who is a psychologist, you're smoking because you want to look like an adult. No, I'm smoking because I'm addicted to nicotine. We want to find that information out from the patient, from them. What is going on? What's your motivation? And withdrawing, distracting, or using humor to change the subject when it becomes uncomfortable. The other things we want to avoid are assumptions. This person ought to change. Well, they ought to change because if they don't, they're going to die. They ought to change. As autonomous individuals, we make the choice to change or the choice not to change. The other assumption, this person wants to change. Well, I got caught with that one just because she was overweight. I assumed she wanted to change, but she did not. The person's health is the primary motivating factor for them to change. That may not be so. The primary motivating factor for some patients could be family. Perhaps I need to be around to take care of my child or another loved one. It could be different reasons for the change to happen. If he or she does not decide to change, the consultation has failed. Well, that's not necessarily true. You may have moved the person from one stage of change to another. It may take a while for them to move to the next stage of change. Now they've gone from pre-contemplation to contemplation. Now is the right time to change, to consider change. That's an assumption. A tough approach is always best. I have to be firm, or you won't make the changes. I would suggest that I need to collaborate with you, point out your ambivalence, and help you identify your motivations for changing or not changing. And I don't have to be tough to do that. I'm the expert. He or she must follow my advice. A negotiation approach is always best. Well, if you don't lose the weight, then I'll give you some medication. Or again, I would suggest going back to the collaboration, getting from the patient the best ways and their successes in the past and drawing from that first. Okay, so you say, well, we still have these patients who are just resistant. They're just resistant. Okay, so we're going to roll with the resistance. Well, how do you know when a patient is being resistant? You might often hear arguing, challenging, might get a little hostile. You're talking to them, they're interrupting you, not listening to what you have to say. Or you're talking and you say, well, do you think you can do that? And they're not answering you at all. Or they seem to be ignoring you. Or denying, blaming. You know, for me, I used to say I was overweight because I have big bones. You know, big bone people, they're easy to be overweight. So I'm making up excuses. So those are some of your clues that the patient may be resistant to change. Okay, so you can explore that. Okay, Johnny, you have big bones, but you lost weight in the past? Well, yes, I have. Well then, let's start there. So going back to eliciting change talk, it really goes back to listening to the patient, pointing out discrepancies, finding out where their ambivalence is, and helping them to see where they are in the change process, the change ruler, the decisional balance tree. So it sounds like it takes a little time sometimes to do motivational interviewing. And you may think, or some folks may think, well, in the doctor's visit or brief interactions, I don't really have time to do this listening and reflecting back. But actually, it's a shorter interaction. You can just do brief interactions with folks to find out what's motivating them to change or not to change by asking the open-ended questions. For example, in the first example, the role play we played, my wife, if she'd have gone to have that particular interaction, I can tell you she would not have gone back to that person again, because she felt, this is from my wife's perspective, and she's shared this with me, felt judged that she's not able to do that because there's something inherently wrong with her. So by just asking open-ended questions, what problems have you had in the past with weight loss? What were some of the barriers you had? You'll get some really good answers from the patient, and collaboratively, you can develop a plan. So it doesn't take that much time to join with the patient via motivational interviewing that can really give you some great results. Okay, so I'd like to thank you for listening today. I've enjoyed talking to you, and I hope that you have gained some information about motivational interviewing. Before I leave today, most importantly, I want to say that motivational interviewing is the practice that promotes a collaborative, person-centered form of guiding to elicit and strengthen motivational change. My belief is that everyone has the ability to change, and as clinicians, we can help them do that. Have a great day.
Thank you for that wonderful presentation, Johnny, and thank you all for joining us. A reminder to those of you who are sitting individually and not in group evaluations that you need to take the appropriate session evaluation found on the website and fax it to 732-489-8599 with your contact information so we may return your certificate. And again, thank you all. And please do join us for the next webinar. This is rescheduled from May when WebEx had technical difficulties. This is What Works in Heart Failure and Updates, scheduled for August 6, 2013. Track